Hello, everyone. I'm Dr. Glenn Gettleson. I'm here with Jasmine Miller, and we're here to do an update on, we call it Jasmine's journey back from one of the worst cases of CRPS that I've ever seen, and what we did to formally diagnose and treat her and get her to the point where we are today. Jasmine was first referred to me through the RSD Foundation. Eric Phillips, actually. I'm a dentist. She was having some very significant dental problems. She's from Hannibal, Missouri, and she chose to get on a plane and come to Long Island, New York, where I am. And we began our diagnostics to include MRIs of her TMJs, MRIs of her cervical spine, nerve blocks that I do. These are things you can see and hear about on my website. It's www.drglenngettlesonTMJ.com. The bottom line is that when Jasmine first presented to me in August of 2021, she was in terrible, terrible pain and disrepair from roughly 13 years of ongoing complex regional pain syndrome. I mean, you guys all know this is the most painful medical condition in the medical literature, bar none. The closest I can come to it would be to talk about a kidney stone that I had many years ago. That's number 3 on the list, and mine was only for a few hours. I cannot imagine what you all go through on a day-to-day basis, week to week, month to month, and year to year. So I have taken upon myself, along with some other reasons I have, to become very involved in the CRPS arena. So Jasmine came to me, we went through a workup, we got the imaging that we needed. As it turns out, she actually had some very, very badly damaged jaw joints, what you call the TMJs. Her injuries go back to childhood. That was never picked up on. She's been to many of the CRPS places that we all know about, the Cleveland Clinic, Mayo, Rochester, and such, and it was missed. And you know what? That happens. But here we saw that she had major jaw joint issues. Now, here's the thing. When you have CRPS that you cannot get under control, no matter what your symptoms are, and based on Budapest criteria, where we look for the pain that doesn't go away, the different kinds, the temperature dysregulation, the fluid buildup, the muscle dystonias that you guys have, where there's spasming and perseverations or non-movement and such, whatever the symptoms are, there's usually going to be a trigger. There were triggers that occur to you in the form of some sort of trauma, that you hit your tipping point, and that tipping point puts you over the edge, and here comes this sympathetic dysregulation. And so it's amazing that patients who come into me, they're pretty well educated and well versed in their condition. The problem is getting somebody to really take it apart and dissect it down and find out what triggers you actively still have that might potentially being kept you lit up. So here's the bottom line. The more sensory pain that goes into the brain, the more sympathetic response that gets kicked out. So it's critical to identify any potential sources of pain that might be keeping the sympathetic nervous system lit up. Those problems can be mechanical, where there's injury. There can be a chemical. There are certain chemicals, heavy metals that can be toxic to the body. There's lead, there's mercury, there's gadolinium. If you've had MRIs with contrast, all of those things can make you sick. And that's because the disease itself relates to other diseases through the immune system. CRPS is basically a sympathetic dysregulation, but it involves the immune system also becoming dysregulated. So you look for mechanical triggers, chemical triggers. You look for emotional triggers. Stress is a major, major trigger because it alters body chemistry. Stress puts pain sensory into the brain, and again, it can kick out and continue to sustain sympathetic dysfunction. And also, you get changes in the brain chemistry, and that's what can potentially keep you lit up. So you have to get these triggers under control. Other triggers, you can have stomach issues. What we're seeing more and more of is that the bacterial flora of the stomach, if it's off, can be a major trigger. There's a connection between the stomach back to the central nervous system. Women, and I know this is for sure with Jasmine, when you have your monthly menstrual cycles, that can be a trigger. If you suffer from bad cramping, any pain into the central nervous system potentially can be a sympathetic trigger that can sustain you and keep you guys in this loop where you're just battling constantly to get it under control. I can tell you the worst thing you can do is to go on any type of narcotic, Schedule 2s. That's your Percocets, Percodan, Vicodin, and such. because those opioids don't do anything except decrease the endorphins in your body. What we want to do is get those endorphins back up, the ones that control pain from within the body and also help to stimulate the immune system in a more positive way. Okay, so Jasmine came in back last October, and we saw what was going on with her. From a dentist perspective, she had some, I'm going to call them horrible things done to her back in her hometown in Missouri. And I know a lot of people call me and they ask me about dental problems that they have from having crips. I hear about their teeth are breaking. And I hear about getting a lot of new cavities and such. And there's a reason those things happen. When you have crips, you can get dry mouth, salivary flow rate goes down, and you're more prone to getting cavities. Teeth can break because you're clenching from the sympathetics causing problems in a nutshell, and not so much the normal trigeminal fifth cranial nerve innervation. You get this override of the sympathetics in the neck that refer to the jaw joint, and you can get this tremendous amount of bite force. So teeth end up breaking. And also you can get muscle spasms in the jaw, just like you get muscle spasms anywhere else in your body. And that those spasms are generating enough force where you can actually break teeth or posture. You can break back teeth, you can break front teeth. Okay, and the other thing that happens with crips is it can be difficult to get a patient with crips numb to do basic dental hygiene and or cavities. That's what happened to Jasmine back home. They knew she had crips. She was diagnosed at the age of 13. She's 25 now. It's 12 years of just this misery that she's been through. So she went to a dentist who doing routine cavities only, routine cavities, where you guys go and get some fillings done. Because of the crips, they couldn't get her numb. And instead of sending her perhaps for sedation dentistry, where they can put you to sleep with an IV and then do the cavities that way, even if it didn't address the crips, at least get the cavities done. Instead, she was sent to a surgeon who put her to sleep, sedated her, but extracted almost all of her back molars. Unheard of to cripple somebody. She was 21 at the time, and leave her with no back tooth support. And they wanted to take out more of her teeth that had cavities because they figured you can't fix them. That's nonsense. There's a lot of bad information out there. There's a lot of bad advice going on out there. So in a nutshell, when Jasmine came to me, the first thing we did, we got her imaging. We saw her joints were badly damaged, going all the way back to childhood. When you look at these MRIs, there is a way to read them and get information that literally dates injuries. You can measure bones. You can see the type of destruction that's there. And the other thing I do is I gave her these sympathetic nerve blocks I do. And if you're interested, on my website, we did a live recording of me blocking Jasmine. You see them being done and you see her response to them. And the bottom line is this: if I block the sympathetics that come from the neck into the mouth, I can then numb the mouth and do routine dentistry. And that's exactly what we did. So we took care of quite a few of her cavities just by getting the sympathetics out of the equation. So you can go to the website and see that. And then from there, we basically just had to get her ready for her surgery. Now, why is that surgery so important? Are we just talking about fixing her TMJs up? And the answer is yes and no. Her jaw joints were so badly debilitated that they had to be surgically repaired. In essence, what has to be done is take out the soft tissue that's no good. There is a cushion in the joint, a little pad between your lower jaw and your upper jaw. And hers was so badly damaged that it had to come out. And the replacement is a fat graft. The fat is harvested from the lower abdomen and it gets put into the jaw joint space, and that becomes the new cushion. So what's that have to do with crips? A couple of things. Number one, to prove that the jaw joints and the damage you had was a major trigger for crips, is that we can give a jaw joint nerve block, and depending on the response we get dictates not only the relief she's going to get for the jaw joint damage she has, but also how much of a trigger was her jaw joint. And she got tremendous relief. Is that about right? This is back in October and then December when we were getting ready for the surgery. So she got this tremendous relief from what's called a fifth cranial nerve block. It's called an auriculotemporal nerve block. And when she got that relief, that told us, A, this is the relief you'll get from the surgery, but also we're going to get a substantial reduction in a major trigger for her sympathetic dysfunction that she has. And the reason for that is because the fat grafts put fat back into the jaw joint, and sympathetic nerves are non-myelinated or non-fat lined type nerves, so they cannot transmit through fat. So once you put these fat grafts into the jaw joint space, there's no longer the ability for the sympathetic nerves to transmit from the fifth cranial nerve in the joint back to the neck and then send her into these horrible spasms that she would get, which we witnessed just by trying to move her jaw around and such. And unfortunately, the problem she had was really crescendoing, getting worse and worse. So she just had her surgery 3 weeks ago. Tomorrow will be 3 weeks. She's in a surgical splint. That's why I'm doing most of the talking, because it's hard for her to still talk. But the relief that she's gotten has been quite remarkable to date. She's not done. There's still healing to go on for the joint. We're still battling to get this CRPS under control because she was so ill with multiple system involvement, to include her stomach issues that are slowly being brought into control, bladder issues slowly being brought into control. Her monthly menstrual cycle has to be brought into control, and we have doctors on board that are going to start to help us with that. However, I have her on a specific medicine protocol now designed to go after central sensitization. That's the big enemy. When you guys get CRPS and you're in this constant flare and rage, it's because the brain cells that are responsible for keeping you in this flare are over proliferating. They're just taking over. So we have specific medications that we can use to bring that proliferation of those types of cells in the brain down. One of them is LDN, low dose naltrexone, and the other one is PEA. That's an over-the-counter medicine. This is designed to quiet down the antagonistic part of the brain and central nervous system that's causing these flares, these cytokines that are responsible for nerve pain and nerve-based inflammation are start to tamp down. It's not like taking penicillin for strep throat where you take it for a week and it's fine. You come in on a very low dose, you titrate it up very slowly over a couple of days and weeks and months, and after about 2 months or so, we get to the dosage that we want, and then hopefully things start to quiet down. So here's the bottom line. Before the surgery and before we were able to introduce these medications, Jasmine's daily pain would be either 10 out of 10 or 12 out of 10. Is that about right? Just incapacitating. And again, I'm doing most of the talking because she's splinted. It was just a horrendous daily pain. She couldn't eat foods because her stomach lining is so irritated and such. Post-surgical, after she got through the surgical part of the healing phase, which is about the first 2 weeks or so, CRPS patients, you guys know you're always going to heal slower and more tortuous, and she was prepared for that. And it's a tough couple of days in there. But now her pain, if it ramps on its worst day, it goes to a 4 once it climbed to a 6. Why? Well, we had the bad heavy rainstorm. You guys know bad weather like that can cause a flare, because when the barometric pressure drops outside the body, any inflammation in the body, fluid expands, and it can put pressure on nerve endings, and that can create flare. Any other parts of her body still bothering her that we're still working on can create further intense flare. However, the worst she's had since the surgery has been, I think, a 6 one day. But I would tell you, by getting her on these medicines that are slowly taking effect, and by blocking her, right now I just blocked her before we started because she was starting to get uncomfortable, going a long day, and I got it down to a 0. That's twice now I've taken it down to 0. And when she reflares, her worst flare, which is usually in the morning time, is only going to about a 3. Is that about right? I mean, so her worst flare now is at a 3, which is not, no pain is ever good, but that's a big, big change from being sitting at 10 and 12 and being stuck there. So the goal is going to be to continually bring this down. And we work on it through medications, blocks, and she's going to be seeing other doctors to help us with regard to gastrointestinal, and then gynecologists to help her with her menstrual cycle and such. Okay, so do you have anything you want to talk about and add in?
So the blocks, they help, and there's many different kinds of blocks, but these are less invasive, and they really help me, and they calm my body down, so I look kind of tired.
Right, so it's a good point. When these blocks kick in, the sympathetic nervous system really tamps down, and I see it all the time. It's not fatigue, it's get a little sleepy. Remember, the sympathetics are fight and flight, and the parasympathetic is rest and digest. So it balances itself out, but it's nice to see someone who's having any pain bring it down to a lower level than it was, and or zero. And again, these blocks, they're diagnostic in a couple of ways. It's not to diagnose the CRPS, it's to diagnose the source of a potential pain trigger, and then also if there's a sympathetic component to it. Because remember, these sympathetic nerves are not nerve to area. That's the sensory nerves, the dermatomes. That's where C1, C2, C3, and you go right down your spine, nerve to area, nerve to area. You guys with CRPS know that when you have CRPS, there's thermatomal involvement. There's four: carotid, brachial, mesenteric is abdomen and pelvis, and then the femoral is the hips down to your toes. They're connected. So you can have symptoms in your head and face one day, and it's in your feet the next. It can be on the right side of your body, and it flips to the left side of your body. The bad news about that is that's a sign of spread. So the most important point about CRPS is to catch it early. And you don't have to wait to have full-blown Budapest criteria confirmed CRPS. This just shows signs of sympathetic dysregulation at all. When I see it, I just get on it. And I might start it. Just sometimes those diagnostic blocks become therapeutic and treatment, because if you catch it early enough, you're just going to break up the sympathetic dysregulation, find out what the triggers are, and then take care of them. Okay, so these blocks help in many ways, but the other important thing to know is that no one treatment modality is enough to treat the CRPS patient. You must do a bunch of things. And the way I liken it is to thinking you have a crazy vicious dog in the backyard, and you want to get that dog under control, so you got to get a bunch of leashes on it. So when it comes, if CRPS is the dog, then and the leashes you want to get on it, there's the nerve block leash, there's the medication leash. Massage is critical. Once you get these blocks on board, these blocks are not just designed for pain or to stop muscle spasms and such, that also they're opening up blood vessels, because CRPS is a vasoconstrictive event. So when you block the sympathetics, blood vessels dilate. And when they dilate, you're going to be able to start getting some of the junk that gets caught up in these muscles that are spasming and such. So that's where massage comes in. And whether you do massage in a massage chair, go for a massage, just put some heat, hot shower, whatever you do, just to get circulation going, because that's going to help you as well. So we've got medications, we got massage, we got the blocks. There's a CRPS diet. There's foods that are not good for you. People don't like to hear it, but alcohol, all your candies and chocolate and such, those things, and coffee, they have to come off the table for at least a couple of weeks, not the rest of your life, for a couple of weeks. And we can help get this thing under control, and then you can reintroduce. Anything else you have?
We should talk about triggers.
About which?
Triggers.
Triggers, right. So we mentioned, well, a couple of things. You know, when you go to see any doctor to treat CRPS, the history is everything. The doctor has to have trained you. You got to listen, and you got to prod and ply. That's pretty much. I do my own interviews with patients over the phone before they even come to me, because I want to verify over the phone that I can help them before I even begin. So I'm listening for history of trauma, athletic events, operations. People don't realize you have an operation that involves you getting intubation or any type of, no matter what it is. It could be a very basic, easy thing. You get stick, cut, sutured, name it. Those are potential triggers for the body to cause you to go into a CRPS-like flare, and or to be the trigger that puts you over the top. It's called a tipping point. So we look for those, and how many do you have? And then the question is, how long have you had your symptoms, and how bad are those symptoms, and what have you had done to date? What medicines are you taking currently, and what did you take? The mistake I think that gets made is that patients just given a whole bunch of medications at increasing levels, increasing combinations, and when it doesn't work, if you're getting treatment and it's not working, then you have to say to yourself, something's being missed. Because my adage is all pain can be traced to its source, or dysfunction can be traced to its source. It might not be the top one, the first layer you look at, but you keep coming down. So one of the other things I do is we get a 24-hour urinalysis study, because that's where I'm looking for heavy metal toxicity. If you're wondering how do I do that, that's where we get it. We have a heavy metal toxicity screen and a basic element screen, because sometimes your basic body chemistry could be off, and we want to see that. If there's any question, I'll send patients back to their primary care and ask if they get full blood panels done, because we're looking to see what's wrong in a nutshell.
I'd like to add that desensitizing your nerves
Right.
is
Well, let's talk about that. Do you mind if I tell you?
yeah.
Okay, so when you start going to different places, you're going to hear about techniques to be done. Um, there's a lot of things out there that are just wrong. So let me list a couple of them. Number one on the list is patients will be sent to some place that have active crips, and they say, geez, my crips is so bad, I have hyperesthesia to the skin. That means it hurts just to touch your skin. And there are places, doctors, centers that will tell you we have to go through a desensitization process. And they'll take a cloth of something similar to what you wear, whether it's a sweater material or a shirt material, and they'll start rubbing on your skin as if they're going to desensitize you to it. And let me tell you, there's zero literature to that and zero science to that. The worst thing is that it also causes pain. Any procedure you do, any technique you try, if it causes you pain, it's no good. Okay, there's nothing good about pain to the patient. Sensory pain in, you ramp up your sympathetics worse. That desensitization protocol where they rub cloth or rub something on your skin and attempt to desensitize. There's not a single scientific article in the literature that's ever been published to say that that works or that it has any scientific validity. So if you hear about that from anyone as something to do or try, you don't. You go the other way. Same thing when it comes to physical therapy. You're going to get different opinions. The best thing I do for people is I have one of these big giant massage chairs here. If you're going to get physical therapy, you don't want it to cause you pain. When they talk about, no, you got to push through the pain, you hear the expression from gyms, um, was no pain, no gain. Okay, not with the Crips patient. No pain is gain because you want to do techniques, mainly massage, just get circulation going to get blood flow going. You don't want to do any treatment, PT wise or otherwise, that's going to cause pain. And let me tell you, the PT should not be getting done by itself. That's where the nerve blocks come in, because a lot of the spasming that you guys have, whether it's in your fingers, your wrist, shoulders, arms, torso, hips, knees, name it, go any part of your body. If you block and get the sympathetics to calm down, now maybe you get some range of motion. But the most important thing really is massage. It's integral to this. Okay, same thing. First line defenses or first line attacks should not be anything that's truly invasive. I mean, I know people talk about spinal cord stimulators. The literature on it is that the success rate is not that high. That doesn't mean it doesn't help people. However, it's a very invasive procedure, and the success rate is not that high. For the ones it works for, great, but the ones that fail leaves you worse off because they have to be removed. Wires come loose, batteries leak, and when they fail terribly. And the thought in a Crips patient, if you assume that you have an electric current going through your body already as part of your heart beating and your central nervous system being active, adding another electric current into your body as a means to control the first one just doesn't really cut it with Crips because the risk is too great that you might cause some sort of aggravation. And when they fail and cause complication, that complication involves pain, and you set yourself up for worsening your problem. Jasmine had that happen to her as an example, a failed spinal cord stimulator. That should not be a first line. Okay, the first thing you have to do is say, where are your triggers? What's going on? So it's look for injury, look for chemical triggers, emotional triggers. Okay, then look for your biochemical triggers, see what's going on, and then begin to treat. So with Jasmine now, we've got her really under control, and we hopefully keep it going. And she also knows there's going to be some bad days that come up where she'll flare, and there's medicine, so she'll get right on, or a blocker if we have to. Right, I have patients call me all the time. I'm in a flare. The dog got sick. My maybe a illness in the family. Something happened. You stubbed your toe. It doesn't take much to light you guys back up, but when that happens, you get right on it, and you do what you know works. And something that doesn't work, then you go to something else, but you control it. It's just like a fever. When you start to flare, catch it when it's low, so it doesn't become that more raging event to make everything worse. The more pain in, the more the sympathetics are going to respond out. But in Jasmine's case, to update, she's doing so much better. Are we all done? No. And we don't quit until if my blocks got her to zero, then we're going to keep working until we get to zero and sustain at zero. not permanent, and she knows that. It's not going to last forever, those zero holds, but we're going to cut that 3 down to a 2, get that 2 down to 1. We're just beginning the process of central desensitization with the medications, the LDN and the PEA. She's on the very early part of that curve, and we've already got her from 10 out of 10 and 12 out of 10 pain and discord down to 2s and 3s that she's even waking up with. And we know in the morning, it usually tends to be worse. When you're asleep at night and you don't move a lot, the sympathetics will dominate and become active to pull blood back, and it's dysfunctional. So you guys wake up a lot more stiffer and a lot more pain. But even that for you now, it's actually much lower. Is that correct? So, I mean, the science is there and the science works. Does it work perfectly for everybody? I don't know. But what you got to do is try. You got to look for your triggers and then see what you can pick off and start knocking things down. I tell people, what if I could knock this down 20% or 15%, anything that is better than what you're dealing with now? Because it's very interesting that as you get pain to come down, other things can follow. And then you just say, okay, well, what's left? If I block you, what didn't the blocks reach? And what level of pain is left, or discomfort, or dysfunction, whatever is there? Okay? You have anything else you can think of?
I would just like to say that many people with CRPS go through a lot of like family abuse and people leaving them and just not having the support that they need. Can you talk on that?
Yeah, it's. I think a lot of CRPS patients know that you get marginalized, ostracized, and it's because it's like you're the loser in the fight, and the second place is an orphan, first place has many parents. So you guys get sick, and it takes some special people sometimes to recognize, whether it's a spouse or a special friend or your relatives, parents, grandparents, name it. A lot of times there's a frustration that sits in, there's an ignorance that sets in, and unfortunately the CRPS patient suffers for it. And unfortunately, that only leads to further stress and can then make you even sicker. So one of the things we talk about is taking those emotional triggers out of the equation as well, as much as you can. I talk to people about that. I'm not playing psychologist. I'm just saying that's a trigger. So you got to learn to get, perhaps we call, be a little more Teflon about it and not let these things get you. The more we get this under control, the more control you have back of your life, and you're not as dependent on other people as you used to be. Jasmine's going home in 2 days back to Missouri. She's going home a different person. She came out here crippled and critically ill. You know what? She's still pretty ill, but she's much, much better and will continue to get her better. She's seen that as well as she's now feeling, it doesn't take much to tip her one way or the other, just a change in the weather. Lit her up quite a bit, getting her monthly menstrual cramps and such. That started to light her up a little bit. So we manage it. Ketamine troches can be a good help, but usually not by itself. You have to have other things in there as well. The ketamine troches work quite well. The sublingual, they help. And what's interesting with Jasmine, before her surgery, I had her on, I think we had 100 milligram troches, were barely touching her pain. Now, when she gets a little bit of a flare, 3 weeks post-surgical, a 25 milligram troche brings her down almost to 0. Is that about right?
Yeah.
So there's the proof in the pudding that if you take away the big triggers, her Georgia was a massive trigger, the main one for her. She has a neck issue too. She has spasms in the neck and such. I just blocked her before we began, just so we could talk about it. I mean, she was in like a 3 or a 4, not feeling so good. I delivered the blocks that are on the website. They're subcutaneous peripheral blocks. This has nothing to do with the spinal cord, nowhere near it. I do them right in the chair. They're minimal to low, very low risk. They're under the skin and over where these nerves are sitting on the side of your neck and in the back of the head. They're loaded with sympathetic nerves, and you block them, it just stops the spread of the sympathetics that might be coming out of the cervical spine area, which is loaded with sympathetic type nerves. And she gets this relief that brought it to 0 and still holding now. Is that correct? Mm-hmm. I mean, it's quite remarkable to know Jasmine back in October and how sick she was, to see where she is now. And it makes it all worthwhile to see these kinds of results. But you know what? It's a battle. And the battle never ends. It's ongoing. And you use science to guide you to do this, to be successful. Anything else? Okay, so that's just an overview. So look, we can pick this up again in another month or so. I'm hoping that in the next month or so, we can come back. Jasmine will be further healed. She'll have the appliance out of her mouth, the surgical guide out of her mouth, and she'll talk a little bit more than me. So you can hear her more. She'll sit in the seat and update you herself as to how she's doing. And any questions, let me give you my email is gl301@aol.com. You can communicate with me there, send me your name, cell phone, and I'll be happy to call you. And my website, www.drglenngittelsentmj.com. And you can see information on this there as well, the video of doing the nerve blocks and a lecture on Crips and the dentist. It's on there as well, PowerPoint lecture you're welcome to view. Okay, so everybody be well, stay healthy, and I say good night.